Alguma pergunta? Gente, eu vou ter que falar inglês por causa da tradução, tá? Então, por causa do cabeamento e para quem está assistindo fora, para depois ser traduzido, ok? Pergunta de Vitória. Dr. Mervyn, what is the main difficulty to monitoring the new protocol, new diagnosis criteria?
Is this on? Thank you very much. Yeah, working. Thank you. I think the main difficulties probably will be in deciding whether the patient has existing SOFA points. You know, so a lot of the time, if the patient comes to the hospital fresh, if they've got no previous medical history, you can assume the SOFA score is 0, or they will be known to the hospital, and therefore you'll probably have some record of a recent blood test for renal function. So I think that will be probably the hardest challenge, is working out what their baseline function was. But I think the majority of patients, that should be all right.
Okay, thank you. And the other question is, do you think that it's more difficult to use the criteria in the emergency room and the ward and the ICU? Is a kind of big difference? You have to change something? Sure. What you do know?
I think, again, the emphasis I put in my talk was on outside the ICU. I think for those of you, presumably many of you here will work in the ICU, we have things a lot easier. The patients already come with a presumed diagnosis, or we have the tools, the staff, to hopefully pick up the diagnosis earlier. So I think, and that's what we were hoping the QSOFA will achieve, we need to look at it prospectively, is to try and pick up the patients earlier on the ward. And I think I 100% agree with what Murillo was saying. You know, the problem's not in the intensive care unit, it's getting them to the intensive care unit. Early recognition, appropriate prompt transfer. So I think, you know, the emphasis is very much on outside the ICU.
Okay. Patricia?
Yeah, we received a question here. And the question is if you think there will be any repercussion on these new definitions in potentially delaying the beginning of treatment of these patients.
I would very much hope not. I think, as we've already heard, there is a problem at the moment in Brazil. So you've got this challenge. You either jump on everybody, which A, will be very inappropriate, and B, will be very expensive, or wait until they're really ill, by which time it's too late. And so the challenge is to think about the problem. If you don't think about it, you won't do anything about it. If you don't think about it, you won't do anything. So if you think about it, you will. And then what we're hoping is that the QSOFA may turn out to be a quick way of picking up the patients at the bedside. You know, I mentioned how in the UK we have this national early warning score, and that will pick up, it's meant to look at any patient who is deteriorating. You don't need, obviously, infection, sepsis is the commonest, but they may be bleeding, there may be another problem for deterioration. But what you need is the nurse, the ward doctor to pick up the problem quickly, start treating, start referring. I don't know if you want to add to that.
I think that if you have a patient with a low grade of conscience and hypotension, specifically, you don't need to have an infection. You just have to act. That's the idea, to use a quick SOFA in the ward or in the ER. It's just calling to receive an early attendance.
Absolutely. And then you can decide if it's infection or not.
Sure, after. But
absolutely.
You have to treat.
Absolutely. 100% agree.
Dr. Singer,
one thing that is important, we don't have to use quick SOFA or the gap of SOFA to do the diagnosis. We just use these tools to screening. If you have a patient with infection and you have a quick SOFA positive or a gap of SOFA more than or equal to, and you have an infection suspicion, run away. If you didn't do anything, you have to do and start as early as possible a treatment. That's the message. The definition is infection plus organ dysfunction. That's the definition. And I think that if we pay attention in these details, like just link infection plus organ dysfunction, we will recognize the sepsis. We don't need to look more and more to the serious criteria. That's the point, in my opinion.
Okay. Dr. Singh.
There was a question.
Sorry.
Sorry, thank you.
Sir, does it work? Are you listening to me? Okay, perfect. Don't think, I'm speaking English.
Thank you.
You don't think SOFA are a very weak tool? Because when I started studying SOFA, for me it was almost a joke, because sometimes you have a very serious patient with a very low SOFA. And when you compare with SAPS 3 or even Apache 2, we have a very different thing to happen here. Okay. And why use a very questionable tool in order to compare the word with that? Okay, your opinion, please.
Yeah, thank you. It's a really important point. I mentioned in my talk, SOFA isn't perfect. The three main advantages, it's been around for a long time. There is, as you go up with SOFA, an increasing risk. So, as we showed in our data, even a rise in 2 with infections associated with a 10% chance of dying. So there is some, predictive validity associated with the test. And because it uses things that are routinely measured, again, it makes it easy. 100% agree, it needs to be modified, but we thought we've already made and offered enough change. We thought if we tried to redesign organ dysfunction, that would be even longer than the 2 years it took us. So I totally agree with you. I think the next step, and it was at the end of my talk, would be now to think about a newer definition of organ dysfunction. But in the meantime, SOFA's out there, so we thought we'll stick with it, but with encouragement to come up with something better for sepsis 4.
It's
I have a question here. I don't know where it comes from this question, but the question is, what factor might still indicate the possibility of sepsis despite a quick SOFA score below 2?
You may have, as I mentioned in my talk, the patient may be hypoxemic, they may be oliguric, but their blood pressure's still okay, their conscious level's okay. I was looking after a patient with necrotizing fasciitis a few weeks ago who had a systolic blood pressure of 60, but he was completely conscious, GCS of 15. So he would have scored 1 SOFA point for that. His respiratory rate was fine, but he was obviously ill. So, we're not saying remove your clinical brain. You're looking at the patient, he's got a rash, he's oliguric, whatever. There are other clues. So if those clues are enough to worry you, so again, prognostically, as a population, he'll be in a lower risk group, but still, some people with a low SOFA, if you leave them, or low Q SOFA, will deteriorate to a high Q SOFA. So again, if you're worried, they're oliguric, whatever, take them seriously. Investigate them, treat them.
It's just to complement the question. It's like if you present in the ER and you have a hypotension. You develop the hypotension. You have some crackles and purulent spoons. Because you have a hypotension like 60, 58, the median arterial pressure, we suspect that you have an infection. Someone goes and collects a lactate, and it's over than 2 millimoles. Would you like that, and you just scored 1 in SOFA, would you like to receive as a treatment?
So the lactate's high. So you've done the patient's ill, that's prompted the doctor to measure a lactate. My personal view is, again, your clinical gestalt, your nous tells you what to do. So usually fluid is the first thing to try. So if you're going to intervene, obviously you want a certain level of oxygen in the blood and a certain flow. So usually fluid is the first thing. And in many, many patients, the lactate will correct very quickly. You know, and I think one of the problems with lactate, and there was a big survey just done in the UK with NICE, which looks at all of the literature, because the doctor measures it and looks at it, it introduces bias into the importance of lactate. And so I think it's, again, another way of reminding the clinician that, well, I have to do something about the patient. But as I showed you with the Surviving Sepsis Campaign database, even a normal lactate is still associated with a 25% mortality with sepsis-related organ dysfunction. So even if their lactate's normal, again, just your point exactly, we shouldn't ignore them.
I mean, this patient is a severe patient, and you need to treat it quickly.
Yeah, that's my question. We have a big problem because if the patient has 1 point on SOFA with low blood pressure, we have 2 quick SOFA criteria, okay, but we have 1 point in SOFA. Do you think if we change the management of this patient, we could delay the initial treatment of this patient in severe sepsis?
Yeah, I think the honest answer is we don't know until we do the prospective study. Chris Seymour, when he did the analysis, and it's published in the companion paper, he showed that in terms of the prognostic capacity, when you added lactate into Q-SOFA, there was a marginal difference from a Q-SOFA of 1, but no added value when the Q-SOFA was 2. So it made a bit of a difference, but it was not huge. And because of that, that's why we didn't feel from the data the need to say you have to measure lactate. Clearly, this is done retrospectively. We need to look at it to see how robust. I have a feeling, you know, lactate has become an article of faith, a religion. And we've gone through, I think the older I get, the more phases of religion I've seen come and go. You know, in English we call it a bandwagon. So, you know, I think I would love to see, please do it in Brazil, the data, looking at lactate, looking at Q-SOFA, comparing the two, adding the two. Is there synergism? And that, I think, will really, really help us to know the role of lactate in the early diagnosis and treatment. So if you believe in it, carry on doing it, please do, but record it and publish the data.
It's important to say to everybody that the new diagnosis criteria is very good to predict the mortality of that patient. It's not a guideline for treatment. It's important.
100%. I hopefully made the point, Bruno again re-emphasized, we're talking definitions, criteria, not management.
Yeah, it's important.
We've got a couple questions, and they're all asking about the exclusion of the recommendation of an earlier measurement of lactate And they point out that people that present with a higher lactate has documented increase in mortality. And it's not such an expensive tool or not that rare. And why that exclusion? Why not even a recommendation? If you have it, do it earlier. It seems like really there is a difficulty in accepting that part of it.
I think it's the religion of lactate. You know, you've got the Catholic religion, the lactate religion, etc. Again, what we wanted to do was rely on data. Good or bad, we had the data. And the data said that lactate didn't offer a huge amount in addition. Again, if you look at the NICE is the National Institute of Clinical Excellence in the UK. They've looked at the literature, an extensive look. I can give the reference to people if they're interested. But they looked at 18 prospective studies in the literature looking at lactate, and they came to the conclusion that you cannot recommend a lactate level as being, this is what we need to worry about. And so all of these data suggest that if you believe in lactate, you want to use it, please carry on using it. Again, what prompts a doctor or a nurse to take a lactate? Do we measure it on everybody with a temperature? Or do we need a clinical prompt? And so again, if you look at the literature, there's no hard and fast rule as to when you should measure a lactate. Should you do it on everyone you take a blood culture on? Should you take it on everyone who's tachycardic? You know, and so again, the literature doesn't help us. And so again, one of the good things I think with the definitions, it's encouraging exactly this sort of debate, and it will encourage the prospective research so we know the answer. Because at the moment, we can speculate, we can look at the retrospective large databases, but the best way of knowing is the prospective data focusing on that question. I don't know if you
And another point is that, as you mentioned, we needed to do a review about the organ dysfunctions definitions. So we don't know if in the future we will consider hyperlactemia as a metabolic dysfunction, as I consider it nowadays. But maybe in the future it can be any statement about it. Like others considerations, when we are using SOFA, we needed some results from lab, like platelet count, bilirubins. So, and we will need something more feasible to do it at bedside and even in the ER. But now I think that we should consider the classical organ dysfunctions definitions, even if you want to look at the SOFA score or only consider the organ dysfunctions definitions that we have in the Surviving Sepsis campaign. But we need to understand that we have to look for the high severe patient, no infection plus organ dysfunction. If it's more severe or less severe, because depends on the severe of organ dysfunctions, but we need to start the treatment. And as you said, we are not discussing management, but we are talking about definition.
Yeah. This is a point that I want to clarify, because since 2004, since the first publication of the Surviving Sepsis campaign and the management of severe sepsis and septic shock, I think that there a big mistake, because like Murillo said in his presentation, some people use the sepsis to open the severe sepsis, to open the protocol to treatment. That's overdiagnosis of this point. I want to know, what do you think about that? Because it's so. I don't know what is in the UK, but in Brazil, some hospitals open the sepsis protocol only with the SIRS criteria.
And again, that worries me. And you made the point in your talk, you're emphasising. Again, it worries me that we can jump on every patient. You know, we could admit every patient in the emergency department with a temperature to the intensive care unit, but clearly that's not sensible, cost-effective, or probably the iatrogenic interventions on the patient will cause them more harm than the infection. And I think that's the challenge. You know, we don't have the perfect diagnostic test. I think there's a big race on for companies to try and come up with better sepsis diagnostics, picking up organ dysfunction much earlier. So I think those tools will be available soon. They need to be validated again. There are, I think at the moment for the kidney, about 20 to 25 different biomarkers. Which ones should we use? They're probably all better than urea and creatinine, but I couldn't tell you which one is the best. So again, we need to have that information. But I think you're absolutely right. You know, many patients with infection, you have a temperature, you go to bed. That's, you know, what a temperature does. It makes you feel unwell. You go to your bed a few days later, you go back to work. You don't need an intensive care unit. And I think that's the challenge. We don't want to cry wolf. I hope that translates into Brazilian jargon. But at the same time, we don't want to miss the patients who could do benefit from early treatment. So, and that's the big, big, big challenge.
Patricia.
Another question about the role of the multi-professional team in the approach of septic patient.
Of the
multi-professional team.
Yeah. I mentioned in my talk about how critical care nurses offer, we have what's called an outreach team. So these are trained critical care nurses who their complete sole job is to support the wards. So the idea is they go to the wards when called by the nurse or the doctor. They're worried about a patient and they can help advise, help with giving fluid, giving oxygen. If they're worried, they call us, the intensive care team, and we come along and decide whether the patient needs intensive care admission or not. So we work very, very closely with our outreach critical care nurses, and we also, and they in particular, try very, very hard to educate the ward nurses to identify and recognise the patients properly. In my hospital, where I work in London, we've got rid of the resuscitation team and we've combined them with the outreach team, because at the end of the day, you want to manage a sick patient exactly the same way. So I was mentioning earlier to Fernando that in my hospital last month, we had 0 cardiac arrest calls. I think on average, we're having 1 a month, because the nurses are looking for the patients earlier and they're being rung earlier. And you can also decide if a patient is not appropriate for resuscitation. They're at the end of their life. And so it would be kinder for them not to put them through CPR. So I think the cost savings of spending the money to have this outreach team can really outweigh the downside of waiting till the patient's really ill. And as Murillo showed, the cost of looking after these patients when they're very ill is very much more expensive than catching them early.
Alguma outra pergunta? Any other question?
I just running out a little bit out of the theme, but I would like to thank you for the observation. 1 code in a month in a hospital of how many beds?
650.
650
That was
beds.
0 last month. Was 0.
Zero last month. It doesn't mean that people didn't die.
Yep.
It does means that people were let die when they were at time of dying.
Absolutely.
We have a hard time with dealing with terminality in our country.
Yeah.
And,
but then
it also means that whatever needed to be done who were not at the point to die was done
Beforehand.
timely. So
100
that's an awesome statement to our reality.
It's really, really, to my mind, really, really important because it means, and in the UK, we're encouraged, I think we're mandated by the General Medical Council in the UK to talk to the patient. You can't make a code decision without talking to the patient. Yeah. And if they're not mentally competent, to their family. And so it encourages discussion about the realities of life and death. And we have, again, I don't know in Brazil, but we have a very good palliative care service in the UK. And so we can get them involved, and they're very good at helping us talk with the families and the patients. So I think there's lots of added benefits from having the outreach team.
What's the mean age of the people in your ICU?
About 68.
68
I think for every year, or even 70, but for every year in the UK we have a national database, and it's going up by 1 year every year. Partly we're not allowed to be ageist, so you can decide on biological age, not chronological age. And I think the average lifespan in the UK is about 81 for men and 83 for women. So we're all getting older. I think now in the UK they reckon children born today will live to over 100.
Okay, thank you.
I have one question. I think that you a brilliant presentation, and you said that the big problem is to change the minds of the people. Yeah, and it's important to us to understand better how or what can we do to change this, because how can we change the mind of the people to understand better the SOFA criteria or the kick SOFA, and to start to use this on ER, on the ward, because it's difficult to us. What is the state of the art to change the mind of the people?
It's a great question, Bruno. You can either do it by obviously threat or incentive. I think one of the problems I think we have in modern medicine today, both doctor and nurses, is that we tend to dehumanize the patient. And, it's bed 5 rather than Mr. Smith. And I think we lose track of the fact that these are human beings. And I get very upset if my juniors or the nurses refer to the patients as bed numbers. And so, it could be my brother, daughter, mother, etc. And we forget that because medicine's become a conveyor belt. And so I think if we just emphasize these are people who could be your family, and would you want them to be treated like that, it then makes people think, they reflect, perhaps I ought to be better. That's one of my favorite questions I throw at junior doctors who have screwed up, in my opinion. I'd say, well, would you be happy if your mother was treated like that? And then they think about it and they go, no, good point. So I think I'm a great believer in incentivizing, and I think if we rehumanize medicine and nursing, that will help.
Thank you. Any other question? Okay. Mirella, we can end the session. That's okay. Well, thank you, everybody. Dr. Singer, thank you very much to share your knowledge with us. It's a brilliant presentation. Thank you, Murilo. Once more, thank you, Amibi, to share us to participation of this brilliant session. Thank you very much.